students. Today we'll discuss a topic which is becoming more and more common, more and more important, and rather much more than that, it is more and more essential. Especially when you do a GA surgery, laparoscopy is a basic because most of the things are switching over to the laparoscopy. Of course, in due course of time, it may go to the robotic surgery also. But this laparoscopy is the basis which is essential. So, even if you are undergraduate, you should know because it is widely used, worldwide it is used. So, you should have a very clarity idea about basics in laparoscopic surgery. That's what I am going to discuss today. So, these are the things I am going to highlight. What is laparoscopy? I am going to that. It is just laparoscopic abdomen, visualizing the abdomen. And of course, through that, you are doing different surgeries. You may do diagnostic laparoscopy, you may do remove appendix, you may do remove gallbladder, you may do a resection, you may do advanced surgeries, you may do hernia surgeries, depending on your skill, depending on the facilities available, depending on the technology, how much higher level you are going to use. Based on that, we can do most of the surgeries. So, history, how it started actually. So, that is important to have idea. Instrument, what are the different instruments for basic surgery, diagnostic and advanced surgeries, what are the different instruments? Technique in brief, we are not going to detail, but brief principles you should have idea. Where all it is used. So, again, we will discuss in detail advantages. And naturally, there are so many advantages, minimal access, no wound pain, and no retraction, recovery part, can go home early, can go to your job early. When there are advantages, naturally, system will have the disadvantages. So, what are the disadvantages? Whom we should not use, that's also important. You can't just take any patient for laparoscopy. These patients are not suitable for laparoscopy. You should have a very clear idea. And for problems and complications, naturally, you should know while dealing with this. Precautions also, discussion, definitely, and we should have. So what is laparoscopy? So, it's a type of surgical procedure that allows a surgeon to assess the inside the abdomen and pelvis without making a large incision. All of you know that. Don't go to make a large incision like olden days. So, appendectomy, neck-borne incision, bust appendix laparotomy. Most of the appendectomies can be done through laparoscopy unless there is a real problem arises and may convert it to open if required. So, begin always with the laparoscopy, the same mode for the gallbladder, like that. So, it is a minimal SS surgery or keyhole surgery. So, large incision is changed over to the keyhole surgery. That is the meaning of laparoscope. Laparo is abdomen, scope is visualization. So, it's an indirect asset, not directors. You are not going to visualize anything. We are going to visualize through laparoscopy, not directly. There is no direct visualization. Indirect through high definition camera, light source, monitor, like a TV monitor, you visualize everything. It's an indirect, no direct visualization, indirect access, indirect skills, and also of course, no feeling. You don't feel. Olden days open surgery, it's a tissue feel. You feel and then do the surgery. The feel is very, very, very important in open surgery, which is not there. There is a bit of a drawback actually. Everything you should assess on visualization. The clarity images are very, very important when you do laparoscopy. So, naturally, it is indirect assess. So, history briefly, we will discuss about history. I am not going to detail it. This is initially started in the talks, and later in 1911, laparoscopy word is laparoscopy, thoracoscopy, laparoscopic abdominal scope is visualization. And that time they used to make a small tube, make a small incision, put that tubular instrument and visualize the abdomen. That's how the laparoscopy has come into the picture. Top beginning, more than 100 years ago. Now, first laparoscopy done by the Smoky and Philip Moore, German, France. And laparoscopic appendectomy done by Sam and or the 1987. And gynecologists started doing most of the hysterectomies, oral set, everything. Then off late, after 1990, everything should go to the laparoscopy in a very big way. Hernia surgeries, tap, IPOM, colonic recession, liver surgery, pancreatic surgery, you name surgery, everything is little bit surgery, nephrectomy, donor nephrectomy, or prostatectomy, urological surgery, everything has become a laparoscopy. Many things have become torgoscopic. So it has taken the last 20 years, 20, 30 years, it has taken over the open surgery into the laparoscopic side. So that is why it is important. So Woodwardia, Mumbai, postulated laparoscopic in India. And so this is the basic history. Now so many things have changed and newer things have come. In the system as the high-tech instruments have come. So what are the basic instruments we should have while doing the laparoscopy? We should have a 0-degree laparoscopy at least. Currently we do 30 degree. You got a different degrees. I'm going to show this one. Initially it takes a 0 degree. Side viewing is better. Light source is important because light, high definition camera, all these things are important. We got two types light source. Halogen and xenon. Xenon is better. Halogen is cheaper. So all the things I'm going to read later. 3-chip camera, CCD. 3-chip camera is a single chip camera is there. 3-chip camera is clarity wise 3-chip camera is better. Now most of the time we use high resolution 3-chip cameras. Video monitor also important. Carbon dioxide insufflation because abdomen is flat. You have to restrain the abdomen. You should have a cavity. Should have a place to do the procedure. Otherwise you may injure your bowel. You won't be able to visualize anything. Your field of vision or field of surgery will not be able to see properly. So there is a distance, or the bowel goes and all other structure will go separate away from your field of dissection. And there is a distension of the abdomen is important. So what is called as a pneumoperitoneum and carbon dioxide is used for that. So you should have a carbon dioxide insufflator for that. You got how much carbon dioxide, how much pressure, how much flow rate, totally how much, everything is assessed because a carbon dioxide inert, non-inflammable. Oxygen, nitrous, all the things can be used, but they are inflammable. It's a very dangerous. You can't use cautery, you can't use energy source. That's why ideal and cheaper is a carbon dioxide to create pneumoperitoneum. So the gas used for pneumoperitoneum laparoscopy is carbon dioxide. It's a very clear, no confusion about that. Should not have any confusion about that. So you got a varus needle to create a pneumoperitoneum. Different dissectors are there, applicators are there, trocars are there, trocars to pass the instrument. So primary port is where you put the camera. Secondary ports are where other instruments you put. They are called working ports. They may have a working port 2, maybe or working port 3. They may have a working port 4, depending on the what type of surgery you are doing, how major surgery is. Suppose for appendectomy, primary camera port 10 mm and secondary working port 2 or 5. For hernia, usually total 3, 10 and 2, 5 mm sufficient. Add lap polycystectomy, you should have 4 ports actually. Primary camera port is 10 mm, then 10, 5 working ports. So total 4 ports. So depending on what surgery you are doing, you should have different size trocars and you should be able to place it in a proper way so that your dissection will go in a comfortable way. You should have a reducer for the instruments. Suppose this is the 10 mm trocar. If your instrument is, suppose this is the 10 mm trocar. If you want to put a 5 mm instrument in that, so gas will leak. So you should have a reducer 10 to 5 mm. Another is going to go through that. That is the 5 mm instrument. Through that you pass it. Therefore reducer. So reducer, depending on the what size port you are going to reduce. So that sort of reducers you should have while doing these surgeries. Energy source is very important because do dissection, you can't use hands, you can't keep on tying also, not technically not possible. So you got a good bipolar, monopolar, ultrasonic dissector, panel bolt, so many things are that we are going to discuss. So energy source is very essential in all laparoscopic surgery. Energy sources are very essential in all laparoscopic surgery to go ahead with the proper dissection. So camera and telescope. So this is like a retina for the surgeon, perception of the images. You should have very clarity images. That's the most important. Unless there is a good camera, high definition, high with camera, you won't be able to go with the proper surgery. May able to do basic surgery. In spite of that, camera is the most important thing. Remember, why only vision? Your decision, your work, decision, everything only by vision, not by touch. Unlike in open surgery, where touch is a very important, essential part to take the decision, where here only vision. So, camera head is called a CCD, charged coupled device, where it perceives the light, perceives the image, then transfer the image to the monitor. So, this 3-chip camera is very, very important. Olden days, initially when laparoscopic came into the picture, we used to use single chip cameras, cheaper also. But clarity image is not adequate. Now, of course, 3-chip camera, where is red, blue, or colors are properly segregated and put into a proper image. So, laparoscopic camera, I'm not disturbed exactly, it's a high definition cameras are visible. You got a couple zonal optical program function selector, focusing, everything is there in that. And the Torch is the very popular company which gives all these very good images. So very popular, beautiful instrument, beautiful images, beautiful camera in Torch company. So these are exactly, it looks like camera. So 3-chip camera, red, green, blue, already told. Pixels are there. Camera it contains gold lens, prism, sensors, optical zoom is advantage to prevent negative effect on all the resolution. So optical images, red, green, blue. So 3-chip device it is. So whereas single chip it is come but clubboard. So this is the exactly camera looks like. This is the instrument look like that. See that all those parts are there. So I am not going to detail it. It's numbered, it's labeled here. You can always go through it and seeing all these things are important. All these connections are important when you use a camera and connect to the power setup. So monitor, again monitor is important, high definition monitor is important, as image clarity, big screen is important, like this big screen is important to use a very clarity image. So resolution should be 400-600 lines, white balancing should be done, once you set up everything, white balancing should be done, otherwise your color clarity will not be proper, so you won't be able to see the tissue properly. So white balancing is the first thing you have to do once you connect the camera, light source, monitor. You club everything, organize everything. That's the most important thing. And there is white balancing is complete, word will come. And usually 20 inches monitor, high definition TV is better, preferably. Most of the time there is a laparoscopic surgery, we record it, unless you can go through that. Most of the time there is a high definition camera, monitors, we record it, so that you can always go through this procedure which you have done later period, so find out any mistakes or technically to improve yourself. So recording also very, very important in this. So telescope, which is the one which you will pass through, that camera is connected with the telescope, so it picks up the image through a light source also will be there. So it picks up the image and it changes into a proper image. Image is transferred to the monitor from the telescope, from the camera, telescope to the monitor. So different 0 degree for diagnostic purpose, initial setting 0 we can use. Eventually 30 degrees ideal because it is a curve, so wide visualization will be there. Some people doing 30 degree camera telescopes, some people 70, depending on. Commonly used is currently 30 degree telescope. That's important thing. You can see how exactly there is a slice here. How exactly 30 degree telescopes are seen. See that? How exactly this, the look image is very clear. So it's optical lens system, sheet is there, all the things are, I'm not going to detail it. Optical fibers, sheet is there, lens is there, light source is there, light was connected there, and so that identification of the image and forms a shift to into the monitor as such. See that is how exactly the image comes. It is connected, this light source, telescope, other end, proximal end connected to the camera properly. And all these things are the components of the Hopkins-Rodler system. Very complex technical engineering method it is. As a clinician, we don't require to understand everything, but basics, connection, everything, how the cup is there, why black spots can come. So we should know the basic connections, how it is connected, why black spots are there. That's basic thing you should know, even though this high technical organization, we don't require to learn the physics of it, but technical aspect you should learn. That's important thing. That's why I've shown this one, how these images can look like. See that 5 mm, 10 mm, usually 10 mm telescope we use, sometimes 5 mm, and those are the 0, 30, 45. What commonly we use is that. This is very most commonly used. Sometimes we use 45, 0 for initial diagnostic purpose. So light source is again important. Two types of light sources are the halogen and xenon. Xenon is better. It gives a white light, very high imaging light source it is. And whereas halogen is yellow light, but it is cheaper actually. So white balance is important before maybe every procedure, each procedure when you start, we should do the white balancing. So best thing is halogen with a cold light source. And these are exactly, it is connected, see that? Light source, telescope, camera, light cable, everything is connected. So this is the connection. We can see that how it is connected there. And white light produces xenon light source is the best actually. Whereas halogen source produces yellow light. It's MCQ question, remember. Xenon, white light. Halogen, yellow light. Better is white light, but it's costly. Halogen is yellow, but it's cheaper. But no, currently, commonly in most of the places, xenon light source is available, and so makes your work easier with the clarity images. So two types of light cables: fiber optic, that's the one which you are commonly used. Fluid gel or gel fluid filled cable. That is cheaper, but again, brightness is not there in gel fluid cable. Whereas fiber optic is beautiful, but maintenance is difficult. It is costly. Get spoiled easily. So instrument care, all these high definition camera, xenon light source, fiber optic cable, we should handle it very carefully. It's very important. So as a surgeon, as a laparoscopic surgeon, it is our responsibility to handle it carefully and guide the sisters and technical staff there. Otherwise, durability will be lost because a lot of money is involved in that. So, taking care of these instruments for benefit of the patient and our own system, that is also very important. So, insufflator for carbon dioxide, I already told pressure is important because distance the abdomen. Carbon dioxide is the one which we use as a pneumoperitoneum agent, and pressure is usually 12 to 15 meter mercury keep. Flow rate is important because gas may leak while doing procedure, and when gas leak, same amount of gas would come and maintain the distension of the abdomen or pneumoperitoneum the stream level. Otherwise, the deflation occurs again. Your field of vision is a lot. Then to adjust again to will take another more, will waste your time. So you should have a continuous source of continuous flow of the carbon dioxide into the cavity, abdominal cavity. Whenever gas leaks, flow rate is important because to maintain the distension of the internal. Some people keep low flow rate, some people keep high flow. Maximum is up to 15, 16. I keep usually 14, 15, high flow rate because there is a wall system. Once the gas leaks only, flow will come enter into the abdomen. So it doesn't have problem at all. And how much gas has entered also it will be mentioned in the system actually. So how to read this one? Also important, this instrument. So we'll have at least basic technical idea you should have how to read these things. Technical idea you should have how to read these things. The trolley, everything you should use the trolley, laparoscopic trolley. So everything is there. Monitor, light source, carbon dioxide, insufflator, cables, connections, everything should have in a trolley so that you can have the very clear, can look into that and see what is the problem, where exactly, whether it's everything's okay or not. And Varus needle is the one which is very initially used to create the pneumoperitoneum. There are two methods to create pneumoperitoneum. One through the Varus needle, second through open method, Hassan's technique. Many people use Varus needle, many people use open technique, Hassan technique. I'm using open technique. Varus is because less invasive. Depending on the individual surgeon's choice, both are equally good, no issue. So Varus needle is the one we should identify this needle while in whenever you want to in MCQ it may ask. It's a very important basic instrument for laparoscopy. It will put a string load there so that once the needle enters, the tip of the needle enters the peritoneal cavity, there is no resistance, it needle moves back. So blunt end comes forward. So it won't injure the bowel. That is the idea of using varus nipple to the spring lobe. So who invented this one long ago? Near 100 years ago, John Varus from Hungary, he invented this one. His invention, his idea is not totally different, because that time pulmonary tuberculosis was very common. One of the treatment for pulmonary tuberculosis, that time it was thought that creating pneumothorax will reduce the disease and cure the disease, which is, of course, currently it is a bacterial condition. You have to do antitubercular drugs in different way. So that point at 100 years ago, that was one of the treatment. So create pneumothorax, whereas introduce this spring load nibble, so that you enter there, it won't injure the lungs. So you can introduce air into that, create a pneumothorax. So later, of course, almost same design with modifications. Same varus needle is used in laparoscopy, become very popular, very commonly used needle. So current indication is for laparoscopy. So how exactly use guard position? Not in the hand like hold in the position like the shown in the lid part. Then push it down and lift and push it down. You can put the 2 ticks. One sort at a sheath, then cadoponium. Then you can enter the pulmonary cavity, the field. Then you can see the air test. Then we put the saline over that. Saline will freely go there. Aspirate and confirm that. Aspirate and confirm that no blood or no bowel contact will come. So there is these texts are important once you put the varus neck, because putting varus needle is a blind procedure. All of the ports we are putting is under vision, but varus needle putting is there is some very less, maybe very less, but some chances of injuring to the bowel, vessel, and so on. There are some chances of injuring bowel or vessel and so on. So this is the limitation. Varus is very narrow, so it will not allow interpolation more than 2.5 liter. So that it is not a rapid distension. Rapid distension of the abdomen may cause compressed IV, sudden cardiac problem, carbon dioxide often, and and so on. So that prevents that. So whereas whatever flow rate you keep, but flow rate is only 2.5 liters per minute. So this is our example to confirm. 2 clicks, hanging drop test, free flow of saline, detention of the abdomen. You percuss over the liver area and other area flank. We can see the resonant area. Tabla sign, let's say, like a tabla, dum dum dum. You can feel. So that's called tabla sign. So liver dullness is obturated, resonant area, percussion. That's why it's said to confirm whether there is adequate pneumoperitoneum or not. So these are the different tests you have to check. Aspirate and confirm whether varus needle is inside or not. That's important. Just showing in this diagram how exactly you'll put the varus needle and what are different parts of the varus needle, string action needle, so that safety purpose is very important and very good here. So this is how exactly we use. And injury problems are, I already told, injury to stomach, vessels, bowel. It's because it's a blind procedure. When the chances are less, still can occur. These are the different settings you can see: insufflator, camera, panel, light source. And remember, all panel settings should be ready before placing the primary port. That's important. Remember, all panel settings should be ready before placing the primary port. Everything should be ready, and should check that everything is functioning. Gas, light source, camera, monitor, everything is working proper. Then only start doing the surgical procedure. So next thing is trocar. Once you put the varus needle, then trocar is important. Usually 10 mm trocar you put again. When you are using a varus needle, distension is there. First primary trocar for camera, usually 10 mm. That's a blind procedure. So you should lift the properly, then guide it little obliquely so that don't directly puncture it. May go into the bowel, sometimes go into the vessels also. I have heard where primary port in a experienced laparoscopic surgeon's primary port is going and hitting the aorta and causing the real problem, hitting the colon, hitting the mesenteric vessels, hitting the stomach and so on. So it is possible in every time, even though you are experienced. So because it's a blind procedure. So you should be very careful. Little obliquely put the trocar, and once you feel the click, immediately remove the port. You should keep trocar. You should remove. Then slowly guide inside that. Then pass the telescope and confirm that nothing is injured. your trocar and bowel intra-abdominal cavity is clean. That is the point. So different trocars are available. Atraumatic trocars are available. They are beautiful trocars, atraumatic. I am using that. Really, the safety is very good in that. So pyramidal, conical blunt Hassan, so the different cannulas, the trocars are available. See how exactly trocar looks like. It will get a wall, trocar and sheath. That is the trocar itself. So all this diagram, this shows everything about how exactly it looks like. So you can always see in OT these different types and different types of trocars, 5 mm, 10 mm. So 7 mm is mainly for laparoscopic sterilization. When you'll be abandoning to the fallopian tube, both sides during sterilization. 7 mm is used. 11 mm, 12 mm in major surgeries where you use when you want to push mesh and so on, thing, push in the IPOM, it will be usable. So different sizes of trocars, commonly it is the 5 mm and 10 mm, remember. So these are the different types. It will be the cutting, non-cutting, conical, blunt, optical trocars. So what trocars you can visualize. So that slowly cuts little bit. So layer by layer you cuts and enter this one. So that under vision you are entering the peritoneal cavity as a in the primary port. That's very useful. So that safety is more in that optical trocars. So these are the rigid trocar. See that you can see the ridges so that it won't come out trocar when you operate. So that if it comes out and disturbs you, trouble. And this is 5 mm, 10 mm, rigid trocar, Hassan's cannula is there. So different types, different designs are available, and disposable, single-use trocars are available, disposable. They are costly, whereas reusable is cheaper because you got to reuse it. Metallic one you can reuse it many times after sterilization, of course, after ETO. So ethylene oxide sterilization. So disposable also available. So the different how we take this at the Hassan cannula below. See that another trocar of exactly 10 mm ridges. Hive top, all those that would modify. All these are disposable types, some and newer types. Just have a look, just have an idea how exactly it looks like. They are costly, but and instruments when they come, basic instruments, usually 5 mm. And when you want to remove the specimen, then you got a 10 mm room or robot instruments are there. Very stout instruments, strong instruments are there. Instruments you can see that Maryland dissector, see the bowel clamp, spatula different types. Again, the hook for male gallbladder or dissection, opening peritoneum it is used. See that hand is without lock, with the lock, graspers, toothed one, non-toothed, toothed graspers. These are very important things. Instruments. These instruments are basic instruments. These are the basic instruments. They are very important for basic laparoscopic surgery or all laparoscopic surgery. Again, same different graspers. It's a liver retractor or retractor for any soft tissue. See that fan, the fan retractor. Sometimes 3 fan, 4, 5 fans are there, 5 pumps are there, and bowel graspers, crocodile graspers, suction device. This is also again important. Remember, bipolar quarter. See that how exactly suction device how exactly used like that. You can see different graspers, liver retractor or tissue retractor, 3 flane, 5 flane fans, fan retractor. It is called as different instruments. See that bipolar cautery. See that suction device, how exactly tooth like beautiful. They are called a suction irrigation device because you can irrigate, you can suck out. So got the 2 like this, one for irrigation, one for suction. So irrigation with the normal salines, chiral normal saline, suction in that. So you got the 2 areas of that. So these are also very important things while doing laparoscopic surgery. Hassan's cannula, this is the beautiful modified Hassan's cannula. For open method, it is used to create pneumoperitoneal incision. Subumbilical, supraumbilical, depending on the type of surgery you are going to do. Then 10 mm incision, dissect, reperplay, use cautery. Then open the rectus sheath, then open the peritoneum. Then put your finger and feel that nothing is there. Then they say blunt trocar, easily without much worry, you can put it inside. Then connect to the carpenter side tube and create a pneumoperitoneum. Then you can go ahead with the placement of further trocars. So this is how exactly Hassan's cannula looks like. Again, different instruments. I'm not going to detail. Just have a look at exactly it looks like. So you can use whatever, whenever you want, whatever you want. So you should have idea as a laparosurgeon what you want in which situation. So situation, which instrument, decision making. That's important. So hand are not hand issues are available, reusable or disposable one. Usually 5 mm diameter. Now what is important is insulation should be perfect. That is the most important. Otherwise, uh, when you do a quadri or when you do a UC energy source, burn up or major burn can occur in the trocar site, abdomen, bowel, all those things. So you should see insulation is proper or not. So when you use energy source, always make sure that insulated part, look at the insulated part, where exactly it is. So beyond that, non-insulated part should not touch any other factor, bowel, vessels, or anywhere area. So this is the most important thing you should be very worried about or careful about. Clip applicators are very useful, especially in gallbladder and other areas. And suction irrigation is the basic instrument for all surgeries. Important. I already shown the picture. Your instruments also available. Packers, endosuturing, this one, different suture materials. Packers, endosuturing instruments, different suture materials, newer one. Also available, remember. So again, this is these instruments are look like. This is the reducer, 10 to 5 mm. This is the reducer, again very, very important when you use 10 mm port for 5 mm instrument. So this is important, reducer. So again, this is the needle holder. When you do endosuturing, this is important. I already shown suction device for irrigation and suctioning. This is also very important instrument. Look at that, how it looks like. So I'm not going to detail it, of course. Suction is important to clear the V. So visualization is better. Suction tip should not get blocked. Two types are there, trumpet type and toggle type. This is toggle type. Trumpet is like this. That's also very stout. Usually 10 mm trumpet types are available. Whereas the toggle type is usually 5 mm. 5 mm, 10 mm both. And a large amount of suction is required. Then you use 10 mm suction device. Usual thing is traditionally 5 mm. Toggle type is commonly used. Many people use trumpet type. So two types are so important you have to remember, trumpet and toggle. This is the toggle type. So again, clip applicator, this is the clips. So how exactly you apply? This is how the important. See that tips are there here, inside. With the hand here. So this is important for wall guard up. We keep the cystic artery, cystic duct, 400, 500 numbers are available. Metric, that is the 400, 500 is the dimensions, remember, 300 and 400 dimensions. Usually 400 for cystic duct, 300 for the cystic artery used. So these are different clip applicators are available, both side of clip usually for clipping. This elbow of the clip should be here. These both should be visualized, and elbow should go and like this. You apply like this, it may slip off. So this is the tubular structure which you are applying the clip. It should be up to here. If it is like this, clip may slip off. So elbow, this is the elbow of the clip. So elbow of the clip should snugly go into the tubular structure which you are going to apply the clip. That's the important thing. Shouldn't be like this, not like this. This is the point you should remember. So this is exactly how it looks like, tip applicator, remember. So different suture methods are available. Barbed suture, so don't record, put the knot. It automatically holds. It got a ridges here. You can see that. It has got a ridges here. So it sharp ridges are available. So how to take bite, needle holders are there. See that how exactly needle holder looks like this. So that different types of needle holders. So this is exactly important. So suturing and knotting is a skill. Most important skill is suturing and knotting. There is important skill which you have to use. So that's how to put the mesh in hernia surgery. See that? So how to use it. So triangulation is important. Adjustment is important. Knotting, C-loop making, everything is a skill like with everything is skill actually. See that? Self-writing needle holder is there so that you don't require to adjust or struggle how to put the needle. So automatically because of these ridges, automatically it holds the needle properly as your requirement. They're called self-writing needle holder. Coil needle you can pass through the procar very easily. Look at that. This is how exactly it looks like. Tackers are used to fix the mesh actually. See that? This is through the tackers are again costly. In ventral hernias, when you do IPON, tackers are very important. Same thing we can in a tap inguinal hernia when you want to fix the mesh to the Cooper's ligament. Again, 2-3 tackers you have to apply. So this is some non-absorbable comes now. Currently, many people use absorbable tackers. So it is like a screw. It to fix that. It to pass through the mesh and fix to the tissue, either soft tissue or ligaments. So these are very important in advanced surgical procedures, laparoscopic surgical procedures. So that the staplers are mainly GI surgeries, thoracoscopic surgeries, when you want to cut a tissue, like a bowel resection rectum, colon, small bowel, esophagus, stomach, pancreas. These staplers are different types, different technologies. Flexible staplers are available for the different companies. These are the important things, remember. First thing is access to the abdominal cavity, which I already discussed. Just I'll run through that. So incision will make it different area depending on the surgery which you are going to do. These are the incision marks actually, all different levels. How exactly you put the port, that is important. I'm not going to detail it. I already discussed that. Carbon dioxide reverse of liver dullness, I have told. Puranga sign or Tabla sign, I have told. How much liters you have to put. Closed method is Veras needle, open method is Hassan technique. I've shown all those into the two methods. Depending on the individual draws, you can have whatever you want. I am using usual Hassan technique. So this is the how exactly making the open method. See that technique, making incision open in the this one peritoneal cavity. Very clearly shown actually. 30-degree telescope use, torch camera, how to hold, how to connect. Everything is shown very clearly in this diagram. This is the connecting the pneumoperitoneum tube. See that? So we have to put into the warm saline or hot saline to the tip of the telescope so that fogging will not occur. So this you put inside, fogging will be reduced. So prevent fogging, it is written very clearly. Then pass the telescope. Again, different steps, pneumoperitoneum, carbon dioxide insufflation, creation, having look at that. Then further port when you put, always further ports are put under vision. See that peritoneum is indenting there. So primary port, secondary port, gas leak prevention, ergonomics are the things most important. Primary port for camera, secondary port for working, gas leak prevention is important. Ergonomics, triangulation is very important. Otherwise, you won't be able to. If your ports are not in a proper place, you won't be able to do proper surgery. That is the point which you have to always remember. So VC port, I've already told. Optical port, visualize under vision. There are blades are there in this. You can pass the telescope and through the telescope you can push it, you can cut it. With the handle you can cut layer by layer. These are called as VG ports. Very beautiful instrument, but costly, usually disposable, so that we can enter the peritoneal cavity very easily across the different layers of the abdomen, so that that's likely to injure any structure there. So this is the most important ergonomics of the laparoscopy, baseball principle. Visualize everything. Clarity is important. This is important. So incision, see that triangulation. This is called triangulation. This is important because primary port camera is here. If handle is like this, then you can work. If it's like this, because sectorization, it's quite difficult, but certain areas you have to use. Ideally, triangulation is especially when you do suturing. Triangulation and sectorization from one side. Laparoscopic apparosectomy is sectorization. And triangulation is like this. This is the very most important. But sometimes you have to do sectorization, but this is more important, more best actually triangulation. Sector is difficult to remember. Lack of tactile sensation. Tissue fill is absent. Only eye-hand coordination. Eye-hand. So look at the monitor like this and do the surgery like this. Hand-eye coordination. That's important. There is no tissue touch. Important. No tactile sensation. Tissue fill is absent. This is a point which is very important. Remember. So again, triangulation meaning sectors in laparoscopy. See that triangulation, sectorization procedures. Just have a look. So principle, straight line principle. There are straight line like this. Surgeon monitor, straight line. So visual is the important. Motor eye is shoulder. If it thigh, you will have shoulder. You should not do shoulder movement. You should not do as less as possible. But mainly elbow and wrist movement. And surgeon stance, look at that. This is important. How you look that. You look like this. You don't look like this. Like you have a neck pain. But look like this. With little lower eye. And image is important. Surgeon stance. Collateral alignment also important. All this diagram shows very clearly what exactly you should follow. This is a different waistline, gaze down you, waistline like this, straight line principle, triangulation. So these are the things, not going to detail it, everything is here actually. So all these principles, you have to always follow these things. That is very, very important, remember. That is a very, very basic principle when you do that. So stance, eye line, elbow positions, all are important, already told. So these are the things. Avoid competing for the space. Dwelling source phenomena. Instruments are getting touched each other, so that resistance is that. Instruments are getting touched each other and resistant to each other. Working against camera and blind spots. your light camera image should be there. Your instrument is somewhere else. So you can't see. So blind spots will be there in the camera sometimes. That's also important. Blind spots will be clear. So all these things are very, very important principles when you work, and rather sometimes hurdles you'll get while operating through laparoscopy. So now again, I'm not going to discuss these things, but port placement, port location, manipulation angle, this is important. The meanings of all these things, target you, elevation angle, azimuth angle is important, azimuth angle, remember. See that how exactly room design, decentered bones, everything. I have not, this slide shows everything, principles about the laparoscopic surgery. I am not to be point detailed, but can always go through it. So physiological changes due to neoperitoneum, just put the slide, I'll not detail it. Carbon dioxide may cause hypercarbia and acidosis, hypoxia, may endanger compression on the IVC, excessive venous return, cardiac failure, pulmonary failure, all those things can occur. Should be monitored very properly. Anesthetic drops are important. Respiratory changes can occur. So CE can be raised. So anesthetic should be well aware of the laparoscopic procedures. What are the problems in compared to the open surgeries? What are the additional precautions that you take is important. So raising the intra-abdominal pressure causes reduction in perfusion of clean mesentery bowel mucosa. So bowel function recovery delays also renal blood flow. That's also important. Intraoperative hypothermia. So hypothermia, perfusion, respiratory changes, carbon dioxide, hypercarbia and carbon dioxide intoxication. All these things are rare problems sometimes. And reduced reduction in the temperature of the body occurs when you use carbon dioxide gas flow. So warmer is important. Warming of the separation gas also may be helpful. So hypothermia, hypercarbia, respiratory problems, raise in the intraabdominal pressure, perfusion, reduce the perfusion of the organs and bowel. All the things are the most physiological changes which you should be aware of, that including anesthetics, so that precautions should be taken to avoid these problems. So how to perform laparoscopic surgery? Position of surgeon, assistant, scrub nurse, camera, patient position, anesthetic position, everything is important. Look at depending on the organ which you are targeting, target organ. These positions are important. Should plan it very properly. Positioning is very, very important in laparoscopic surgery. Otherwise, we will find difficult to do it with the surgery. That is the point important. So always, most of the time under general anesthesia, many laparoscopic surgeons now do gallbladder and appendix under spinal anesthesia or epidural anesthesia. But ideal, textbook wise, GA is a must for all the laparoscopic surgery, remember. So due to done in full-fledged operation theatre with all facilities, with all asepsis, that's important. You should not do in a uncomfortable OT at all, with everything available. That's the point which is important. So distension, pneumoperitoneum here, outer course, insufflation, everything is there, secondary point and so on. Again, same thing, how exactly inside looks like. So they look at this, how this looks like inside. Look at this, how it exactly it looks like, how outside looks like that. This how exactly. Monitor will be there, of course. And again, same setup. Again, same looks, so that eye angle is like this. Your wrist position is like this. Everything is very clear. Visualization. It's again, same thing here. High tech. How would be actually? Again, same thing, just visualization of different setup here. So, hand-assisted laparoscopic surgery, Hall's surgery, it is otherwise called as Hall's. Initially, it became very popular, maybe 10-15 years back. One port, you put the hand. Surgeon will put the double gloved hand. These gloves are specifically made so that they prevent the leak of the Catholic. Other two are instruments so that you go to the dissection like colonic surgery, rectal surgery, and so on. With the hand, you feel, and other instrument you do dissection. You do dissection also with this hand with the tissue feel. Of course, it was become popular 15 years back. Now it is totally gone because advantages are not much. And so this is how exactly, see the photo clearly shows. Hand port it is called. This is the laparoscopy port. And then this is how exactly you do the procedures. Few people still do it, but does not have much additional advantage. So along with the laparoscopic instrument to perform complex procedures. So gas-led laparoscopy, if gas is not there, gas is inadequate, or mainly most of the time, patients are not suitable for carbon dioxide, respiratory problem, heartache problem, hypercarbia, carbon dioxide is not at all possible to give them. So you should have a distended abdomen. That's very important. What is it doing to surgery? So this is the abdomen forward. So that will have an inner skate to do your surgery and manipulate the force without any pneumoperitoneum, without creating any pneumoperitoneum. You create a space there, which is called gatlet laparoscope, or otherwise called the laparo lift. So different instruments are there. Hold the abdomen like this, lift it. So they see that how it lifted. Then put ports, then do the surgery. So again, technically it's a demanding and not very popular, but still, so people still do this procedure. Remember, it's called laparo lift or gasless laparoscope. Just run away. These are the ports for laparoscopic cholecystectomy. All of you have seen. This is the Strasbourg critical view of the city. Only two structures are there. Cystic is should be clear. Cystic artery duct, CBD is here. So Hartmann's pouch. So this is exactly gallbladder. Basic thing, 4-port, important. And gallbladder in laparoscopy of exactly, it looks like different ports and steps, of course. There is a colored triangle. Rouvier circus, MCQ question. This is the line of dissection actually. So this is the CBD. This is the colored triangle. This is the cystic duct artery there, gallbladder. Strip off the peritoneum and dissect cystic artery and duct and apply clip. Already shown the clip applicator for 300 for the cystic artery, 400 for the cystic duct. See that gallbladder outer fold, colored triangle and liver. See how exactly clips are applied in the cystic artery and duct. So appendectomy, again it is sectorization. See that primary port, secondary port, like this. Depending on the choice, you can put how exactly appendix looks like in laparoscopy appendectomy. Again, these are the different ports. Some people put like this, how exactly it looks like. Then monitor surgical steps. You can see that inflamed appendix, burst appendix with the suppuration here. You can see again suppurate the appendicitis with infection. So endoloops are placed actually. Catgut vehicle endoloops are available. Minimum two you have to apply proximally. Of course, under open method, you go through the primary port, palmar point, left upper abdomen, left contact region, and through that then identify, dissect. Unless very close to the peritoneum, you have to cut the adhesions, otherwise you may injure the bowel. We should use sharp dissection. Sharp corti or scissors can be used. So all these are, you can see the bowel adhesion, dense adhesion. Everything can be released properly through laparoscopy. So ideal approach is laparoscopy for visualize it, remember. And hernia, of course, tap and tap, totally extraperitoneal hernia mesh repair. Transabdominal periperitoneal mesh repair. Both can be done through laparoscopy for the inguinal hernia. Look at that. Hernia is here. See the triangle of doom, triangle of pain, and corona mortis, circle of death. All those points are important for you to remember. You can always read my SRB manual of surgery, clinical methods in surgery, and learn these things for hernia examination, clinical methods in surgery, and manual of surgery for the detailed understanding of the hernia chapter. Everything is given in hernia chapter. You can always go through my manual. Of course, operative surgery gives a step-by-step hernia surgery, so all different types. And IPOM, incision hernia or ventral hernia, is it accurate or place? Exactly. Looks like usually from this point you can apply dual mesh actually, costly it is. So many gynecology conditions are done through laparoscopy. Ectopic pregnancy, myomectomy, hysterectomy, oophorectomy, laparoscopic malignant surgeries, everything can be done. RPLLD, retrobladal lymph node dissection. So laparoscopy has taken lot of taken lot of procedures from the gynecology. So all this thing can be done through laparoscopy. Remember, infertility management, hysterectomy, tumor removal, chronic pain, ectopic pregnancy, everything. So ovarian cyst, to see that ectopic gestation, hysterectomy have exactly to do. So diagnostic laparoscopy is a basic thing for identifying diseases. All investigations are not very sure. We want to take biopsy, you want to take a fluid, you want to take a tissues. That laparoscopy is identified above something. You can take biopsy, you can visualize peritoneal biopsy, ovental biopsy, tissue biopsy, and fluid collection for analysis, AFB, tuberculosis, malignancy, peritoneal carcinomatosis, different malignancies, everything can be done. We can decide before doing surgery if it is peritoneal the malignancy, then radical surgery is not possible. So decision making also have fall in laparoscopy. Cirrhosis of the liver, septum, tuberculosis having multiple tuberculosis are there. So the second is umbilication due to central necrosis, typical of the second stage in the neck. Umbilication is the typical of second stage in the liver, not in the neck, sorry, in the liver. Typical multiple secondaries with the umbilication due to tumor necrosis. Very typical of the liver secondaries. Colonic surgery is very popularly done laparoscopy currently. So many instruments are there. Lateral surgeries, anterior section, lower anterior section, then sigmoid resection, colonic artery camera, total colectomy, then abdominal resection with the colostomy, making colostomy. Everything is done through laparoscopy currently with, of course, advanced high-tech devices. So energy sources in laparoscopy, so that all these things are the energy sources: harmonic, scalpel, thunderbeat, electropottery. I'm not going to detail it. We go through my manual of surgery, everything is there in the manual of surgery. We can go through my operative surgery book. In detail, energy sources are there with the proper explanation, diagrams, illustration. Go through my book, SRB's Manual of Surgery, current edition, and SRB's Operative Surgery, current edition. It's in detail about all these things. You can go through that. And all these things are required: CUSA, bicola, ligature, hormone couple. All the things are used in different places in laparoscopic surgery. And thunderbeat, because what is the meaning of thunderbeat? Thunderbeat is the faster actually, with less smoke actually. Smoke is very less in thunderbeat, remember. And harmonic scalpel, and harmonic scalpel also very useful actually. It's called very basic, the basic instrument for advanced surgeries. Most of the people use harmonic scalpel. It is for dissection is very, very useful. Thunderbeat is much more better, but costly it is. So all these things are different energy sources which are used in laparoscopic surgery. It is very essential. So what are the exit seals? What are the advantages? It is written there. You can always go to this charts actually. So indication for laparoscopy, diagnostic, vigilance to find out, already told, like all these basic surgeries, surgery for hernia, and advanced gynecology surgery, I already told. May all major surgeries, if you are skilled well, if you got a proper functional knowledge, if you are trained well, then you can do most of the surgeries. And always you can convert when you are find difficult. That's the point which you have to remember. Remember, conversion is not a failure, it's a decision. When you find difficult, you can't go ahead to the laparoscopic surgery of any surgeries. Immediately think of conversion and do a proper surgery. Finally, at the end of the day, patient safety and concluding surgery is most important. So compromises these two things, we cannot go ahead with anything. And you find difficult, call somebody else. They also find difficult. Your team is finding difficult, and straight away convert and finish the procedure, do a proper job. Take care about the safety of the patient is the most important. So advantages, I'm not going to detail it. Non-invasive and less pain, easy fast recovery, quick return to function, cost messages. All the things are the magnification. All these things are the advantages. HGRS is a depth of the magnification. Everything are the advantages. So preparation should be same as open surgeries. Post-op but recovery is faster here. And it is many laparoscopic surgery, the gallbladder, appendix, ediciolysis, diagnostic laparoscopy, laparoscopic ovarian system can be done. Hernia can be done as daycare surgery, especially in Western countries. They do as a daycare surgery. And disadvantages are expense, amount, setup is important. Small setup, if it is not available, high tech is required. So both should be available. Skill, learning, and it is only visual hand-eye coordination, no tissue touch. And so that skill learning is important. Skin learning is important, remember. So instruments retrieve the touch, there is no touch. Physiological concerns, you have to remember, all that we told, what are the physiological concerns, position, difficulties, and possible complications they should remember. So observed contraindications are hypovolemic shock, massive bleeding, hemodynamic instability, severe cardiac disease. So all these things are the observed wounded, and don't do laparoscopic surgery in these patients because you may lose the patient because of the systemic failure, cardiac failure, respiratory failure. So don't compromise the life of the patient. That's the most important. Relative retinal disease, internal obstruction, organomegaly, aortic aneurysm, uncorrected coagulopathy, cirrhosis, portal hypertension, multiple surgeries, all these things are the relative contraindication. Depending on your skill and choice, you can go ahead either laparoscopy or open. So just as the revision, I tell you what are the complications of laparoscopy. Already I have discussed complication due to carbon dioxide, complication due to port placement, complication due to the anesthesia, carbon dioxide narcosis, respiratory failure, hypercarbia can cause, and port placement, you may injure the bowel, you may injure the vessel, you may bleeding from the port side can offer, you may injure the epigastric arteries. And specific surgeries like gallbladder may injure the CBD, appendix may leak, and resection may leak, bleeding can offer. So shoulder pain to the patient, that's important. And problem to the surgeon. Surgeon will get tired, exhausted, long procedure, can't do it with the procedure, finding it difficult. You also get neck pain, shoulder pain, stiffness, and so on. So all these things are the different complications, diathermy related, surgical complication, fashion factor, postoperative community, anemoperitoneum. So everything actually I have mentioned in different slides actually, which is most important thing you have to remember. So general, so trocar side complication, postulate complication. I'm not going to detail it. A position of exactly it is categorized, or the slide is very important when you think of complication during laparoscopy surgery. So newer methods are there, just remember, newer methods are there: natural orifice transluminal endoscopy surgery, single incision laparoscopy surgery, 3D laparoscope, spider, it means single port instrument delivery extended reach. Newer thing, of course, spider, it may be available only in higher centers, and because of flexibility and triangulation, it's very easy to do the procedures. So the difference is so many newer procedures are available, remember. This is exactly single, only one incision is there. So port is like this, see that? Everything is through single incision. See that? Telescope is here, instruments are here, everything is through that only. See that? Look at that. So with that only, but like manipulation is difficult. Your visualization difficult. Small image, small range of image or visualization. So technical is a demand. Mainly appendix, gallbladder, or electrolysis can be done. But in moment you find difficult, put extra port. That is important. It's called single. Cosmetically, it is important. So only thing. 3D camera for a high clarity image. 3D camera for high clarity image. So indigo cyanin, you can inject this one and see, especially in the gallbladder, you can see that green color, very cystic very cystic artery, very CBD, all those things can be visualized so that you avoid injury to the common bile duct. Same thing, vascular pattern also can be identified. Indigo cyanin injection makes lot of difference in laparoscopic surgery. Laparoscopic ultrasound, it is very, very useful to identify the structures many times, remember. Video assisted thoracoscopic surgery now become very, very popular. Sympathectomy, mediastinal removal of the tissues, lung conditions, decortication, all those could be biopsy, everything can be done through this thoracoscopy. Remember, here pneumothorax is easy to create, and because stiff thoracic cage is unlike pneumoperitoneum. So robotic surgery become day test one. You can surgery very comfortable. So high definitions. So many instruments are there. With a console, you can sit and do this. It's comfort to the surgeon and patient also. Quality work you can do in robotic surgery. The movements of the instrument is 360 degree. So manipulation is very good. Suturing, knotting, dissection will be much more easier and proper and specific actually. That is the advantage of robotic surgery. So I'm not going to detail it. Open advantage, open laparoscopic robotic discharge stage, everything about the advantages and disadvantages of these things, cost factor, learning curve, everything is there, all these things. So surgery, asset is the skilled one. Laparoscopic surgery is much more skilled one. It's a long learning curve. Keep on doing, repeated learning, training. Endo trainer, keep on doing it. See the surgeon, myself, daily doing the daily, daily you have to learn. Training this one with the laparoscopy or hand movements to be skilled, especially suturing. So it's a continuous process to keep updated with that. Daily skills, recollecting is the most important thing. Laparoscopy surgery to learn and to maintain the skill. That's also important. If you don't do it repeatedly, then your skill will go reduce. Your skill can get reduced. That's the important thing. So it's a daily learning curve. It is a difficult to soon. Learning is very, very important. Skill learning is most important. Triangulation is important. So students, all these things, go through my manual, clinical methods in surgery, go through my manual of surgery, go through my operative surgery current edition. So I request all students and viewers, so subscribe my YouTube channel, SR Surgical Insight, share with your friends, and press the bell and learn surgery daily. MCQs are coming, like many lectures are there. Lot of lectures are there. Go through that, view the lectures. It is a free, learn surgery on day-to-day basis. Also, once in 2 weeks, we'll have live sessions where students present the case. Many other than me, many other professors will be there, senior professors. They will have the interaction with the student for 1.5 hours, like hernia, breast lump, thyroid, varicose vein, vascular cases, swellings, everything we discuss notes in 2 weeks. So that introductory section, you can join that, you can chat and put your questions and learn surgery in different way. So how to present a case, a practical point you can learn very well with the proper discussion. How to approach a patient, that's also important. And it's very useful for your exam also. Live session, whoever join, they'll get a certificate which will be useful for your future career. Again, request you to subscribe my YouTube channel, my YouTube channel, and learn surgery easier way, better way, on daily, day-to-day basis. So again, request, go through my manual of surgery, have my clinical method surgery, which contains all the clinical examination properly, step by step, lot of photos, but no treatment strategy. But each chapter has got the QR code, which has got a video how to examine patient, for hernia how to examine, breast lump how to examine, thyroid how to examine, vascular disease, venous disease. So you can learn surgery with the differential then tabular formally chapter, so that you can learn clinical surgery in a easier way, faster way. And also my manual of surgery covers everything I had for CBM syllabus, neurosurgery, specialty, gastrosurgery, thyroid, breast, vascular disease, surgery, with the quotations, illustrations, management principles, lot of photos, diagrams, illustrations. So it is complete book for anybody, undergraduate, postgraduate, and a beginner's surgery with the principles. So have my manual of surgery. They got a lot of MCQs online. MCQs also very helpful for your NEET exams. So it is a complete book for any student who learn surgical principles. So have my SR-based manual of surgery, have my subclinical method surgery, learn surgical skill by going through my operative surgery, experience your big voluminous blood, and also subscribe my YouTube channel. What the lot of videos are there daily, and MCQ daily comes, answer the MCQs and enjoy learning surgery as such. Students, I hope you have understood this basic in surgery, laparoscopic surgery very well. Thank you so much.